Hello, I'm Ben Wattenberg. Was Sigmund Freud right? Is most mental illness rooted in childhood trauma, often sexual trauma? That Freudian view has shaped much of the modern world. Now, a new school of scientists say many disorders of the mind are really physical diseases of the brain and can often be treated with new drugs. Joining us to sort through the conflict and the consensus are four noted psychiatrists. Peter Kramer, Associate Professor of Psychiatry at Brown University and author of the best-selling book, Listening to Prozac. Fred Goodwin, former director of the National Institute for Mental Health and now director of the Center on Neuroscience, Behavior, and Society at George Washington University. Daniel Weinberger, chief of the National Institute of Mental Health's Clinical Brain Disorders Branch and co-author of The Neurology of Schizophrenia, and Milton Viederman, professor of clinical psychiatry at Cornell Medical College and an attending psychiatrist at the New York Hospital. The topic before this house, the brain versus the mind. Has Freud slipped? This week on Think Tank. What do you think of when you hear the word psychiatry? Does it conjure up an image of a taciturn therapist listening to the recalled childhood nightmares of his or her patient? Well, times have changed. Much of the treatment of mental illness has gone high-tech. Proponents of the so-called new biology say that disorders like depression, schizophrenia, and manic compulsive behavior are often caused by physical or chemical defects in the brain. The cure is not years of talk therapy, but treatment with new drugs. For example, the drug Prozac relieves depression by increasing the chemical serotonin in the brain. Doctors have prescribed Prozac to more than 11 million people worldwide. Defenders of traditional talk therapy praise the new scientific advances, but stress that doctor-patient communication is still crucial. They worry that too many doctors will rush to prescribe potent medicines without first trying to talk through their patients' problems. Gentlemen, doctors, first question, starting with you, Dr. Fred Goodwin. Is Freud slipping?
I think the image of Freud in the Woody Allen sense is slipping, and appropriately so. Psychotherapy is not slipping. Actually, in a way, the evolution of drugs has been a gift to psychotherapy because it's taken away some of the things that psychotherapy didn't do so well in, schizophrenia, manic depressive illness. What you see today is psychotherapy being used more focused, more briefly, with the medically ill and with the severely ill psychiatric patients, but in combination with, not instead of, medications.
Dr. Dan Weinberger.
My sense is that rather than slipping, things are changing. The field is changing. All fields of medicine are changed to be placed.
Okay. Dr. Milton Viederman.
The question really poses a false dichotomy. That is to say, the dichotomy between psychotherapy and biological psychiatry. Freud himself believed ultimately that mental illness could be reduced to biological factors. Moreover, he was not at all a believer in the idea that environmental factors uniquely influence development. He felt constitutional factors were very important. So in essence, Freud himself was a participant in the current evolution of psychiatry.
All right. Dr. Kramer, Peter Kramer.
I think the scope of biological interventions has expanded so that now it is possible to do things biologically, even for the very minor mental disorders and for nearly normal people, maybe for normal people. And that makes for very exciting psychotherapy. That is, you can sometimes allow patients to alter their perspective through the use of medicine and integrate that alteration into the psychotherapy. So based on intellectual ferment alone, these ought to be very exciting days for psychotherapy. I think insurance companies and external pressures on the field may lead to a different outcome.
Well, now, are you sort of all closing ranks as professionals like to do? I mean, you had a system of treatment where at times people went 4 or 5 times a week for an almost infinite number of years in psychoanalysis. And now you have, for some of those patients at least, somebody writing out a prescription once. Now that is not just at the edges or shades of gray.
Well, I think that the caricature of psychoanalysis as an infinitely long process, 4 or 5 times a week, without a defined end, is really a caricature. Psychoanalysis itself has changed enormously in recent times, both in theory and in practice. Currently, the very idea of seeing people in psychoanalysis, what we call psychoanalysis, 2 or 3 times a week for shorter periods of time, is becoming current, for one thing. Moreover, psychoanalysis is not in opposition to the biological psychiatry in that drugs often facilitate, as Peter indicated, what happens in analysis.
I think the bigger question that we're being asked is that the tradition of psychiatry was a tradition that emerged from certain principles of psychological organization. And this field is evolving like all fields of medicine and treatment in most fields of medicine. At the time that psychoanalysis began, it was a therapy that grew out of the efforts of certain people to understand the emergence of physical symptoms in people that didn't have physical illness. And there were no other treatments at that time. Psychoanalysis was the best treatment on the street in Vienna at that time for people who had paralyses that didn't explain themselves in physical terms. We are in a state of transition now where there's question being raised within the field of what are the best treatments. I think it would be ill-advised and bad practice as a physician to treat a patient with a medical illness such as depression might turn out to be primarily. We don't categorically know that yet, but a lot of data suggests it is. If it turns out that that's a medical condition that requires a medical treatment, we should counsel that patient and get to know that patient and help fashion the patient's aftercare as positively as we can, the same way a good internist would do with a patient with hypertension and diabetes and everything else, which studies also show.
The paradox now is that today the most dramatic evidence for the efficacy of psychotherapy are in the medically ill, you know, the enormous rates of change in recurrence of cancer with psychotherapy, and in patients who have real biological illnesses like schizophrenia and manic depression. You can produce 3 to 4-fold differences, but not with traditional long-term analysis, but with social skill training, with psychoeducation of the family. It's psychotherapy, but it's of a broader, more practical, more here and now focus than it would have been in the past.
Fred, I want to emphasize an issue here, and then I'll come back to that problem. And the issue has to do with specificity. The problem of, one of the things that psychoanalytic theory can contribute is a understanding, a structure for approaching the patient, a model for thinking about that. And what I would emphasize is this, that utilizing that model, specific treatments can be developed.
How do you come into this?
Well, a couple of things. One is just this past week I was teaching the residents about outcome studies, and I think that the outcome studies are terrifically hard to do, and one thing to be said about them was maybe they shouldn't have been done given the level of technology that was applied to them. But the broad summary, the broad summary is that
there's a conflict here.
Right.
You are doctors,
right.
And most doctors or most pharmaceutical companies have to. I mean, treatment has to be certified. Well, in the pharmaceutical case, by the Food and Drug Administration. Right. There's peer review among doctors for certain kinds of surgery, and it's got to show that it helps. And you are saying you don't have to show that it helps.
Well, I'm not. Of course, one should show that it helps, but it is possible to do studies that are invalid. That it's possible to try to apply technology that's not ready to a problem that needs to be answered. I mean, there are a lot of things we don't know in medicine. Outside the area of drugs, we don't know whether prenatal care is really all that helpful for to obstetrical outcome. We think it is. But the studies really are hard to do. They're
showing that
we need to step.
Well, there's some that show that it is.
Ben said psychiatry in general. We need to step back a minute because we had to review this whole thing at NIMH for the Clinton Health Task Force.
You were the director of the NIMH, is the National Institutes of Mental Health.
Right, the main government research organization. Right. I had to bury myself in this literature for a year and a half in order to be able to present it. The things we found were straightforward. One is that the diagnosis of mental disorders is as good or better than most medical disorders. That is the ability to agree. We can agree better about the treatment of diagnosing depression than doctors can agree about a mammogram as indicating cancer. The second thing is, in the 5 major mental illnesses, the treatments were as effective as they are in areas like cardiovascular illness, but most of those treatments involved combinations of medication and psychotherapy. And the evidence for the psychotherapies, and I may have to disagree with my colleagues, but the hard evidence that we could present to the Clinton task force were on cognitive therapy, behavioral therapy, and
it's just a very fast example.
cognitive therapy
Right.
is helping a person restructure the way they're thinking about themselves, finding islands of self-esteem, letting them see in very practical ways how they have perceptions which distort their view of reality, and it works. Behavioral therapy, for example, in my field of depression, is having somebody find a behavior that they do that they realize makes them feel better when they're doing it, have them repeat that. That's a little simple-minded, but there's a number of behaviors. There's deep breathing exercises for anxiety attack. These things work. They're short-term enough to be evaluated, and then a specific kind of interpersonal therapy where you teach people different ways to negotiate with others. This is not going back to how you felt about your mother, although how you felt about your mother may be affecting how you're negotiating.
I'm genuinely shocked.
But interpersonal therapy has some relationship to the structure of analytic therapy.
Yes,
although I agree that it's very frustrating.
We get too shocked.
You know, let me get shocked for a minute, because
Peter, I was only talking about the literature. I wasn't talking about what I believe as a clinician.
Right.
And I agree with you.
Well, let's talk about what we believe as clinicians
I agree
for a
with you.
moment. because
Doctors practice a lot
I
of
love
things.
seeing psychiatrists argue. That's just wonderful. Go ahead.
I think it would be frightful if all of a sudden we were to throw out what to me is the most highly developed technology in psychiatry, which is insight-oriented dynamic psychotherapy, traditional
Hold on.
psychotherapy.
You must put that in American, right.
Traditional psychotherapy, based in a broad sense on Freud's principles, I think is still the most developed technology within psychiatry and most useful
And yet you
for the
have written
minor common
the
disorders.
leading popular book, at least, about the use of drugs, Listening to Prozac.
That's right. I think that medicine has entered that same arena where psychotherapy traditionally has been minor disorders, problems of personality, and it's necessary to say that we can influence a lot of those problems biologically.
My concern is, and I think that how this debate gets started and what the public and the managed care companies, which we don't really talk about this, but fuel this debate. Ultimately, it's economics that makes this question be asked right now. What they're demanding of us is that we look very critically at what works, what doesn't work. We as a field, I don't think, should be defending a citadel. We should not be defending psychotherapy. We should be defending our patients, their illness, and their need for treatment, and we should be doing what is best by way of treatment.
So if
to
people
answer your question,
who are less severely ill, you don't have to go 2 or 3 times a week for a year,
Well,
but you
I
can just
think
write out a
Peter's
prescription for Prozac or anything else. That's fine.
I think Peter's book answered the question very nicely. It illustrated something that we've all experienced as practitioners, that we can see a patient who has the archival neurotic syndrome that was the basis of many of Freud's fundamental writings, something called obsessive compulsive neurosis, a condition that psychoanalysis built itself around in many, many ways. In many, many ways.
Yes.
For good reason, because it's a condition with very rich internal mind dynamics. Many patients, despite years of psychoanalysis, have remarkable responses to a medication such as Prozac. When you see this clinically, you can't not, as Peter did, I think, and it instigated him to write this book, take pause about that and say, my, this makes us have to now that's not to say...
Hold it. I want to read you an outstanding piece of psychiatric literature. This comes from a Broadway musical, West Side Story, that came out in 1957, and it's a song but with that juvenile delinquents sing to the infamous Officer Krupke, and it says, "Our mothers are all junkies, our fathers are all drunks, golly Moses, naturally we're punks. Gee, Officer Krupke, we're very upset. We never had the love that every child ought to get. We ain't no delinquents, we're misunderstood. Deep down side of us, there is good, there is good."
Right.
Now, this is sort of the essence of political Freudianism. You know, it's not my fault. or it's not his fault, or it's not anybody's fault. I say political.
But it's a risk.
Well, I don't know
right,
what
it's a
that
risk
means.
that.
Right. Let us talk about.
That's not Freud's view.
Okay. Well, it's my view of Freud's.
Let's get him off the
One
hook.
thing you're saying is that environment has an effect. We know environment has an effect. And environment has effect on the biology of the individual, and it has an effect on the psychology of the individual.
If you have a handicap in a wheelchair, you still have to somehow make your life work, even though you have a handicap. If you have a handicap that might affect your emotional functioning, you have a responsibility to get treatment, and you have to be a collaborator in that treatment. Having something wrong with you does not absolve you of human accountability. An alcoholic, we know that early onset alcoholism is very genetic, and people get it after their first drink often. But it still takes a courageous act of will every day for that alcoholic not to drink. And some do and some don't.
But the question that we see in the policy community all the time now, and specifically, for example, on that question of alcoholism, is if the alcoholism allegedly isn't the fault of the person, does the society owe him a living?
You can make the argument that the biological view makes society more responsible. Let's say it's discovered, which it more or less has been, that putting people in terrible social circumstances affects the biology of their brain. In that case, you might say society is more liable than if it merely affects their psychology. It's not clear to me that the Freudian view is the liberal view. It may be that the biological view will have liberal aspects.
Part of where this gets so confusing is that we have conflated in our thinking about public and social psychiatry and psychology illnesses with human variations in personality and behaviors. And what Freudian psychiatry has been very helpful at, Freudian psychology, is understanding the vagaries of a number of ways that people react to circumstances. But it has not been helpful in understanding the basic underpinnings of disease. And there are diseases that we call psychiatric diseases, such as major depression, schizophrenia, panic disorder, and certainly other obvious conditions where thinking about psychogenesis, that is the causation of the disease being rooted fundamentally within these constructs of psychological has not proven to be the case.
Absolutely.
But that's a very different issue.
We're in agreement.
Right. It's a very different issue to understand that people come by their personalities honestly. The more we have begun to understand the complexities of genetic information that people inherit from their ancestors, the more we've come to realize that people inherit predispositions to react to their environment in certain ways. And we're, increasingly becoming, having the wherewithal to appreciate that some people may cruise through environments for reasons having to do with their biology that for other people, because of their biology, are devastating.
It seems to me what you're doing is that you're mixing frames of reference. There is a question of moral judgment and responsibility. This is what Fred was talking about. That is separate from motivational systems and dynamics. If you are motivated to kill someone because you want to kill your father, should you therefore be excused from responsibility for that crime? No one would argue that the moral issues and those values are separate issues.
To go back to your antisocial kid, they used to say that crime was due to poverty. In fact, the great majority of poor people don't commit crime. It's stigmatizing the poor to make it into poverty. In fact, if you look at what predicts it, about 80% of all the youth violent crime is 7% of the youth. No relationship to race, no relationship to poverty. The only environmental thing which correlates with it is not having a father. And that happens in the middle class, it happens in the urban areas. And that's social behavior, which I happen to agree with you, that we have to think carefully about what are we subsidizing?
Are we buying out of wedlock birth?
If you ask the question about where Freud slipped, I think this gets closer to where he slipped. And I don't know that it was his slip, really. It was his apostles that slipped. He made the comment. He made the comment that after his trip to America, as I'm sure you know, that America would embrace his ideas like no other country on earth. It wasn't clear that was a compliment on his part, but nevertheless, probably where it slipped was a promise that many people heard. It may not have been offered, but many people heard it, that all of society's ills could be explained and perhaps mollified in Freudian terms. That was a slip. flip. That's not
and
correct.
I think that's true, but I want to go back to something that Dan said, because I think it'll clarify the discussion right now.
We're running a little out of time.
All right,
so-
and that is the issue of the relationship between biology and environment. That's what's running through our discussion. We're all in agreement on this. We know that kids are born with temperaments. We can measure them at the beginning. They're very different and the like. We also know that genes don't simply determine behavior. Genes offer a range of possibility for interaction with the environment. And so the ultimate product is a mixture of the two, and the scientific problem is to tease apart the contributions of both of these factors.
Peter,
And Freud would have
you
said
want
that.
to come in one?
I think we're a little out ahead of ourselves in believing that we really have biological answers to either social or individual problems, just as we were once ahead of ourselves in terms of psychotherapy, and that we really have models for biological solutions more than we have evidence that our biological models are correct.
We have just about come to the end of our time. Let me ask you a question we like to ask on this program, and sort of go around the horn, starting with you, Dr. Goodwin, which is, just in brief, what do you agree upon and disagree upon within this group or your field?
My main concern about this discussion and argument is it may give the impression that there's not a consensus. There is a consensus in psychiatry, and our knowledge base is as solid as any other area of medicine. There's lots of medicine which is an art, some of it's a science. Our science is increasing. I think the role of psychotherapy is changing. It is often looking at its best when it's combined with medication. Treating people with schizophrenia requires medication. Depression, severe depression, requires medication. But psychotherapy looks good when it's helping medication.
Dan?
Well, let me just say what I agree with, and I don't know if it's been articulated, is that psychiatry, which is nothing new for psychiatry, experiences itself as under siege. My own sense is that what the field all agrees on is that mental illness isn't going away. It's a very serious problem. Patients have very serious illnesses, and that we have much more effective treatments now for these illnesses than we ever did. What's on the horizon, I believe, is we will understand at a much more fundamental scientific level the biology of these disorders, how patients are born with dispositions that are much more elaborate than just whether they're passive or aggressive, but very subtly defined predispositions at the level of neurobiology that make them respond to a variety of environmental circumstances. This will give us the wherewithal to intervene more judiciously at the biological and environmental side.
In other words, there are more new drugs coming along.
Many, many more new drugs.
Dr. Viederman, Milton Viederman.
Well, I think that we have a consensus about the essential issues, because we did focus on the issue of environment versus genetics and constitution. That is central. I want to express a concern, really, and that is that my own experience is that the power of words is a very central feature of the role of the doctor, and that the current pressures, understandable, are now pushing us to minimize that, and the consumer complaint that they don't have relationships with doctors is going to accelerate in the context of our inability to engage patients.
Dr. Peter Kramer,
I
last
think
shot.
these are intellectually tremendously exciting times for psychiatry. I don't know that in 10 years or 20 years our models of what is illness and what is health will look just the way they look now. My main concern is that in that process we not lose this wonderful technology, which I think of as a technology, and not just counseling, of psychotherapy in all its variety.
Okay. Thank you, Dr. Kramer, Dr. Goodwin, Dr. Viederman, and Dr. Weinberger. And thank you.
We at Think Tank depend on your views to make our show better. Please send your questions and comments to New River Media, 1219 Connecticut Avenue Northwest, Washington, D.C. 20036. Or email us at thinktank@pbs.org. To learn more about Think Tank, visit PBS online at pbs.org. And please let us know where you watch Think Tank.
For Think Tank, I'm Ben Wattenberg.
This has been a production of BJW Incorporated in association with New River Media, which are solely responsible for its content.